I'm delighted to say that the last session of the day, we have a treat for you. If you have ever wanted to say, I wanted to get an update on what are the recent studies in deprescribing, and I want to learn that information in a really fun and entertaining way, well, we have just the people for you, fresh off their stint for opening for Taylor Swift on the Eras Tour. We have two fabulous presenters, Amy Linsky and Kristen Zimmerman. Amy is Associate Professor in the Division of General Internal Medicine at Boston University and also multiple centers, the Choir and Grech Centers at the VA Boston healthcare system. And she has done extensive research and other scholarship on deprescribing and related topics. Kristen Zimmerman comes to us from the great state of Virginia, where she is an associate professor at the Virginia Commonwealth University in the School of Pharmacy. And she's a program director for get all the acronyms right, ACCP, ASHP, and VCU, Congressional Healthcare Policy Fellowship Program. In addition to that, she is also active both in sort of scholarly work and clinically in the topics we'll be talking about today, medication reconciliation, deprescribing for older adults. They have been the star performers at prior sessions of this meeting in updates on deprescribing research. We are delighted in having them back to close us out. Thank you, Amy and Kristen.
Nothing like setting the bar high.
Yeah, seriously.
Oh, and I was told to tell you that their presentation would be terrible,
Yes.
so that would sort of set the bar low. So,
Excellent. Thanks, Mike, for having me and Kristen back again this year. As you figured out, I live here, and what you might not know, Kristen was born and raised here. So this time around, you're going to get a local's guide to deprescribing. You might walk out of here able to pronounce some town names like Worcester and Gloucester, as well as you can pronounce those generic medication names. So no conflicts of interest, these are our opinions, et cetera, et cetera. Some abbreviations that you might see throughout this presentation, many of them you're probably quite familiar with, but just in case, I'll give you like 5 seconds to peruse those. So on our tour today, you have some learning objectives. We're gonna start out talking about differences in clinician attitudes and behaviors by specialty. We're going to stick with the clinicians and think about how we can make their deprescribing actions maybe a little bit more confident in doing so. We're going to switch over to the patients and think about their perspectives and interest and agreement with deprescribing recommendations. And then we're going to bring it all together and talk about some interventions, as well as the safety and cost effectiveness, cost consequences of those interventions. So let's get started. So the first study I want to talk about wanted to look at the differences in attitudes and behaviors for de-intensifying medicines for older adults with type 2 diabetes, specifically looking at physician perspectives on de-intensification, the frequency of doing so, and some facilitators and barriers. Now, if the content seems a little bit familiar, we presented a parallel study from the same group last year about patient perspectives. So this was a national mail survey of US physicians, either in general medicine, geriatrics, or endocrinology from June of 21 to March of 22. And they were asked, when considering patients age 65 and older with type 2 diabetes, to rate the importance and frequency of their decisions to de-intensify diabetes meds or to switch to a different diabetes med class. And then they were asked to select barriers and reasons for de-intensification. Overall response rate, not so bad for physicians, 37.5%. Mean age was 52 years with 21 years in practice. You can see the gender and racial breakdowns. Across the specialties, they were pretty similar in terms of demographics, but there were differences by practice types and locations. So what did we see with respect to their attitudes towards de-intensification? So 80% said that they thought that de-intensification was important or very important. And this goes up to 92% for the importance of switching diabetes med classes, mostly driven by the differences there in the very important rating. So if they think it's important, do they actually do it? Not quite as much. Only 14% said that at least half the time they de-intensified diabetes meds. This does go up a bit to 31% for switching diabetes meds. And we talked about the differences by specialty, so let's see how those shake out with respect to de-intensification. So general internists, I'd like to think of myself as maybe an exception in this category, said that they rarely or sometimes de-intensified meds. This was more commonly seen in the geriatrics respondents. Endocrinologists were much more likely to report that they switched the medicines. With respect to the barriers to de-intensification, 2 of the top 3 were really related to perceptions of the patient. So the first one about reluctance, reluctance for increased blood sugar, or patient reluctance to change medications. The others were, the endocrinologists were a little bit more likely to report that there was concern for increased short-term hyperglycemia. Moving away from patient-related barriers, there was a bigger, more ratings by general medicine respondents about concerns about diabetes quality metrics. And the geriatricians were more commonly to report that there was concern about interfering with another provider's prescribing plan. So what got people to deprescribe? And importantly, across the board, it was about safety, about reducing the risk for hypoglycemia. When we look at the ones that really differ by specialty though, the geriatricians really seem to be the most concerned about overtreatment in terms of rating the A1C target being below goal, or that there's limited life expectancy as a reason to consider de-intensification. So can we overcome these differences? Hopefully it'll be a little bit easier than that Red Sox-Yankees rivalry.
Let's go Sox.
But what we did learn from this study is that attitudes aren't necessarily linked to behaviors. And it also makes me wonder, is switching good enough if we can't fully deprescribe? Now, switching was not one of the D-somethings in Natisha's talk earlier today, but maybe it should be. We also know that subspecialists are probably an under-targeted clinician population. And what I found also really interesting was that several of the top barriers were related to perceptions of patients, but from other work that we've all probably seen, I'm unsure how accurate that really is. So, if you're in town and you're interested in catching a game, they're playing tonight and tomorrow at Fenway Park. If you think baseball is like 6 innings too long, there is a tour of Fenway Park that is very cool. Lets you go inside the Green Monster, and I would recommend that. So, moving to our next stop on the tour, we talked a little bit about how we saw that difference between how often de-intensification was happening compared to what people thought was important. So how do we get them to do it a little bit more? Maybe it's about increasing confidence. So this study wanted to see if deprescribing whiteboard videos could increase clinician self-efficacy for deprescribing. You're probably familiar with whiteboard videos, concise animated videos with real-time illustration and narration, very pragmatic, very scalable. There were 4 videos of 3 to 4 minutes each. You can see a screenshot here from the more general why deprescribe, and then there were 3 medication-specific videos. They were promoted via social media deprescribing networks. Some of you guys may have seen and participated in this study. This was back in January of 2019 to October of 2020. And there was an optional survey before and after watching the video where you basically rated your confidence level from a 0 to 10. And if it was 7 or higher, it was considered to be high self-efficacy. Some of the items on the surveys included the extent to which you saw yourself practicing or promoting evidence-based prescribing, that you could identify and engage with patients, write a tapering protocol. So there were over 1,000 views from 212 unique IP addresses. Of that, there was 368 video watchings that had a completed survey both before and after. Clearly, women were more commonly responding to the surveys. Also, 35% of the respondents were pharmacists. 28% were nurses, and under 20% were physicians. The remaining were students, researchers, and other people who were interested. So what did they find with respect to increasing self-efficacy? You are not supposed to see the details on this graph. If you are, I'm impressed. But ultimately, each of these is a different item on those surveys. And the blue is the rating before watching the video, and the orange is after, and every single item showed an increase in self-efficacy from before watching to after. So clearly, these whiteboard videos really show that there's an increase in self-efficacy for deprescribing. They're short, they're brief. We've all probably gotten sucked into a YouTube rabbit hole of watching things like this. What I did notice, though, from seeing these results was the majority of the people who responded to these surveys were not physicians, who are the ones who often are doing the clinical prescribing. And so how do we get clinicians to watch these, the physicians to actually be watching these. So one potential idea, this is a little bit of maybe a coming attraction before watching a movie over at Coolidge Corner Theater in Brookline, not technically Boston, I learned that when I moved here, but also a really great neighborhood to walk around even if you don't go see a movie there.
Great first stop on the tour, Amy. Coolidge Corner is also one of my favorites, but if you go, from my perspective, the absolute best thing about Coolidge Corner is getting a bagel from Couples. But we're not here to talk about my perspective on bagels. We're here to talk about maybe patient perspectives on deprescribing, which just happens to be our next objective and our next stop on the tour. So to do this, we'll look at one study which explores the extent to which older adults accepted a deprescribing recommendation associated with a hypothetical vignette and saw how that acceptance of that recommendation was impacted by either medication type or rationale for deprescribing. So this was a cross-sectional evaluation of 6 hypothetical deprescribing vignettes for a theoretic 76-year-old woman called Mrs. EF who had polypharmacy, multiple chronic conditions, and some pre-specified health beliefs and values. So for example, she was like really motivated to care for her health but didn't want to take a lot of meds. And participants were randomized to receive a scenario that either featured a statin deprescribing recommendation or a PPI deprescribing recommendation that was founded in one of 3 deprescribing rationales. So either lack of benefit, potential for harm, or a combination rationale. So here, participants included older adults aged 65 and up, recruited from 4 countries, and the authors primarily sought to assess rate of agreement with deprescribing on a 6-point Likert scale, anchored by strongly disagree and strongly agree. Specifically for this statement, I think that Mrs. EF should follow her PCP's recommendation and stop taking whichever drug was featured in the vignette. The authors also assessed the influence of specific covariates, things like personality traits, prior experience with the med featured in the vignette, and how that influenced agreement. When we look at the characteristics of respondents, mean age of 71, you can see some of the demographic breakdowns here. Respondents were taking a mean number of about 7 meds, really didn't need a lot of help with those meds, a pretty health literate bunch. What I think is pretty interesting though is that about half of all respondents reported either current or past use of a medication in the class that was featured in the vignette that they received. So a lot of concomitant use. When we look at overall rate of agreement with the deprescribing recommendation, it was really pretty high, 4.71 on that 6-point Likert scale. But when we look at those results by drug, what we see is that there was a significantly greater rate of agreement with deprescribing that symptom-based PPI as opposed to that chronic statin. So it's not clear as whether that's related to drug factors, whether that was influenced by some characteristics of the vignette. So for example, the patient, Mrs. EF, wanted to continue to take meds even if the benefit was small. So in theory, could that have led respondents to want to continue the statin? We don't know. When we look at adjusted analyses for predictors of agreement, we see that PPI is more associated with a greater rate of agreement than the statin scenario. And consistent with prior literature, we really see the power of featuring the harm rationale, which was also a significant predictor of agreement in this evaluation. What's really interesting to me is that past use of the medication featured in the vignette was also associated with greater rate of agreement. Now we can look a little bit deeper in this next pair of studies, which comes from the same research team, and here they examined factors that were associated with agreeers and disagreeers to this deprescribing vignette. So the authors here conducted a content analysis of these agreeers or disagreeers. So in the paper by Vordenberg and colleagues, they looked at older adults who rated their level of agreement a 5 or higher on that Likert scale, and who also included a free text response related to their agreement. And we'll contrast that to the paper by Weir and colleagues, which looked at respondents who disagreed with the deprescribing recommendation. So a rating of 3 or less, who also included a free text response. So we look at characteristics of respondents, again, really similar to what you would expect in the original study and pretty similar between papers. There are some subtle differences though amongst disagreeers versus agreeers. Disagreeers, we see a higher mean number of total medications as compared to agreeers, so perhaps that was some level of influence. But what's even more interesting is when we look at current or past use of the medication featured in the vignette that was received, we see a much greater rate of current or past use amongst disagreeers as opposed to agreeers. Now, this isn't broken down or analyzed any further in this paper, but given what we saw in the earlier trial, I can't help but think that there's probably some influence here of past use versus current use on whether or not somebody's agreeing with that deprescribing recommendation. So if we look more at the qualitative piece and we look at the common themes that emerge when the authors analyze the free text responses, amongst agreeers, we're seeing this sort of theme emerge about deference to the GP as one of the most common domains that was featured, followed by medication-related themes. And these med-related themes really, in a sense, support the rationale for deprescribing. Now, this is in contrast to what we see amongst disagreeers, where they're more commonly expressing doubts about deprescribing, kind of similar to the themes that we sort of have talked about a little bit here today. And those doubts about deprescribing were largely related to doubts about whether it's even needed, what are the possible consequences, how do we go through this process, and a need for greater communication. So when it comes to patient perspectives, can patients all agree? Overall, yeah, I think they can. The overall rate of agreement was really pretty high at 4.71. We do see some influence of medication type and some really powerful influence of the harm rationale and some influence of past use. What I think is more interesting is the relationship between the GP and that influence on agreement. Similarly, if we were thinking about this theme of communication, communication is really a necessary component to delineate that rationale for respondents and to address doubts and concerns. So I think that that's really kind of the secret sauce, perhaps. So as Bostonians, one thing that we can all agree on is that Dunkin' Donuts is way, way, way better than Starbucks. And as your resident historian on this guide, I'm obliged to tell you why that is. That's because Dunkin' Donuts was actually born right here in the Bay State, just outside the city limits in Quincy, Mass. Still stands today, though it's been nicely renovated. So you don't have to go to Quincy, though, right, to grab a cup of Dunks. You can pretty much get Dunks on any street corner, in fact, right down the hall over in the Prue. If you do stop and get a cup of Dunks, I hope you'll try my favorite. This is a toasted almond iced coffee, milk, 2 Splendas. But yes, check it out.
Excellent. So I strongly also agree with that Dunkin' Donuts recommendation. From a donut perspective, though, if you want something a little bit more local, Union Square Donuts and Blackbird both have really intriguing flavor combinations, and you can find a lot of them. There's some different outposts around the city. So we talked a lot about clinicians. We talked a lot about patients. Let's try to bring the two together and think about some interventions. So the first one we're going to talk about is an intervention called Ariba PPI. And this study wanted to see the effectiveness of a computer-based shared decision-making consultation aid on PPI prescribing. So Ariba is an acronym in German, which you are not going to learn about, but you will eventually get the Google Translate version of it. But it's a shared decision-making tool that's meant to be used in real time. You can see a screenshot from their website. Basically, that the clinician and a patient are together looking at the computer screen and working on this together. The software itself for Ariba has been around since 2010. There's other existing modules that came out before, so for anticoagulation or cardiovascular disease prevention, and they came up with a new one for proton pump inhibitors. So Ariba, 6 letters, 6 steps. Here's the English versions. So to begin, you actually define the task and the goals. Then you talk about the risks from the subjective perspective, really the patient's perspective about taking that medicine. And then you talk about the risks that are more objective, the clinician perspective. Come together, the program generates some different prevention options, talk about the possibilities of them, and then come to an agreement on what to do next. It's also meant to be very visual, patient-centered. There's a traffic light display and a printout of recommendations to hopefully consolidate the information. This was done as a multi-center cluster randomized controlled trial of general practices in Germany from November of 2018 to July of 2019. The GPs had to be conducting their practice in German and tech capable. Patients only had to be age 18 or up, so this was not a geriatrics-focused population, and they had to be chronic PPI users defined as 6 months or more. The primary outcome for this study was a defined daily dose of the PPI at 6 months after the intervention. And the secondary outcome was essentially that same difference, the PPI dosing, 12 months later. So the randomization worked. The practice characteristics between the groups were completely the same. You can see there in terms of the GPs. Same thing for the patient characteristics. Randomization worked, although technically slightly longer duration of use between the intervention group compared to the control group. Doesn't seem all that clinically meaningful, especially given that across the board, the mean duration of use was more than 5 years. So these are very much chronic users. So the first thing we want to talk about is what happened at the time of the intervention. So you can see that in the top row here. Roughly 1/3 of the patients who got the intervention or were in the intervention group decided to discontinue their proton pump inhibitor. But when they followed up with the patients 6 months later, only 42% of those patients were no longer taking their PPI. 58% at that point, 6 months later, were still taking their PPI for a variety of different reasons. With regard to the study's primary outcome of the differences at the 6-month mark, they did actually see a reduction. That darker gray line with the dropping slope is the intervention group, and there was a statistically significant reduction in the defined daily dosing of PPI prescribing at 6 months after the intervention. But if we follow that out 12 months, there's no longer any difference. So this is supposed to be a very patient-centered intervention. What did the patients think about it? There was a sub-study done that was an interview with 30 subjects to understand how they experienced counseling with the Ariba PPI tool, and then ultimately what were the factors that influenced their deprescribing decisions. The demographics of the sub-study were essentially the same as the parent study. The thing to note here is that the interviews happened roughly 8 months after the intervention, so whether that impacted the ability to recall, possibly. 17 out of the 30 reported that they had the counseling with the Ariba PPI tool. So many patients did not even have exposure to the tool itself. Of those 17, only 8 recalled the visual content. And the majority of those 17 didn't have any change to their PPI. So what did determine deprescribing decisions if they didn't either use the tool and they don't really remember the tool? Kind of similar to what we just heard, the patient-clinician communication was a large driving factor. And they also talked about health problems and symptoms and the availability of alternative treatments. So what if we expand our interventions beyond patients and clinicians? And this study specifically comprised a deprescribing bundle to try to understand how this bundle could impact deprescribing of a DBI contributing medication, drug burden index, at discharge in older adults, and then also the deprescribing of different DBI contributing drug classes. So this is a comprehensive bundle, so we're going to go through it in steps. So the intervention itself had 4 components. The first was a DBI clinician interface in the electronic health record, and get a sense of what that looks like. There's also a deprescribing guides and consumer information leaflet, so the patients may have seen something like this. There's also an electronic health record component that the DBI score was integrated with the pharmacist patient list, and an educational component talking about polypharmacy in older inpatients. So the 4 things there are just the intervention. There's also then further augmentation in what was called stewardship, where a clinical pharmacist was integrated into this intervention and would identify patients who had a DBI greater than 0, complete a medication review, come up with a list of deprescribing opportunities, and then talk with the treating clinicians. So it's a non-randomized controlled pre-post study at an urban hospital in Australia. From December of 2020 to October of 21, you can see the sequencing of the timing there. So the control period, intervention period, followed by the stewardship, which is the intervention plus the pharmacist. Patients were admitted to geriatrics medicine services for at least 48 hours, 75 and up, and had to be on at least 1 DBI med. The primary outcome was the proportion of patients who had at least one of those DBI meds deprescribed at discharge, and the secondary outcome was looking at differences by the different med classes. In terms of the patient population, these characteristics were pretty similar across those 3 time periods. The only statistically significant difference was lower prescribing of opioids at admission to the intervention patients. So what did they find? So in the control group, just under 30% of patients had at least 1 DBI med deprescribed at hospital discharge. And this goes up to 37.5% when they introduced the intervention. But this is not statistically significant. So now we're going to bring in the pharmacist into it. And now it goes up to 43%, and this is a statistically significant reduction in difference in DBI meds. When we look at the secondary outcome by class, the first thing to note here is the antipsychotics, even in the control group and then increasing over time, more than 50% of the antipsychotics were deprescribed at hospital discharge. So the geriatricians are already doing a pretty good job of recognizing the harms associated with these medicines. In terms of the intervention or the stewardship actually having an impact, though, the only statistically significant difference between the different time periods was for the opioids, where there was more deprescribing in the stewardship period than there was in the control period. So we just talked about 2 interventions, and it makes me wonder a little bit more about what's the path to success with them. So the Ariba PPI did have a short-term effect, but that goes away at 12 months, and further, patients don't actually remember using it. They didn't use it half the time in the intervention group. And the comprehensive bundle was also affected, but where we really saw the differences was not just with the electronic intervention, but once that pharmacist was integrated into the intervention. And so the 2 of these things combined, these 2 studies are really making me question again the technology versus people and what's really the driving force. If you want to learn a little bit more, though, about people of Boston, you can go to Faneuil Hall or one of the many other stops along the Freedom Trail.
Ooh, another good stop, Amy. Freedom Trail is one of my favorite things in Boston. As you can probably tell, weird, obscure Boston history is like totally my jam. But if you're on the Freedom Trail and you're making your way to Paul Revere's house, I highly suggest that you stop at one of my favorites, which is Trillium Brewing's Pop-Up on the Rose Kennedy Greenway, and you can try an authentic New England IPA. It's actually one of the best rated in the country, so I suggest you try it. All right, so moving on to our next objective for today, we're going to talk about deprescribing safety in older adults, and we're going to do that by digging a little bit deeper into the OptiMed study, which sought to assess whether deprescribing impacts survival and quality of life in older adults living in long-term care facilities in Australia. So the OptiMed was a randomized, double-blind, placebo-controlled deprescribing trial that also had an open intervention arm. Participants included those 65 and up, living in long-term care, taking at least 1 regular medication. And participants were randomized to one of 3 arms: an open deprescribing arm, so traditional deprescribing, right, where meds were tapered or stopped over time and everybody was aware, or one of 2 blinded arms where the target medication for deprescribing was over-encapsulated, right, so that neither the patient, the research team, any of the nursing staff involved in med administration had any idea whether or not the medication was being changed. And so those 2 blinded arms, there was a blinded deprescribing arm where meds were, of course, tapered inside that capsule over time, and then when they were stopped, replaced with the placebo capsule, or the blinded control where the over-encapsulated med was continued. And participants were followed here for 12 months post-randomization or until death. So the real cornerstone of the OptiMed intervention is the development of the medication withdrawal plan. And to develop the med withdrawal plan, first target meds were identified. And so these included solid oral dosage forms of either scheduled or PRN meds. And the meds were identified following a structured deprescribing algorithm really based on the GP-GP algorithm. And so once those target meds were identified, a deprescribing plan was developed, and up to 3 of those target meds could actually be deprescribed simultaneously. Most meds were tapered if they needed to be tapered over 2 weeks, unless it was sooner, if it was a long half-life drug, or if it didn't need to be tapered. So this was really a consensus-driven deprescribing plan as well. So 2 study pharmacists independently developed the deprescribing plan, came to a consensus on what that deprescribing plan would be, and then had to get GP agreement prior to participant randomization and starting out on the deprescribing plan. So participants were monitored weekly after each dosage change for adverse drug withdrawal events or any reason that the medication would need to be restarted, that the deprescribing plan would need to be stopped, or that the medication deprescribing plan would need to be delayed for some reason. So here's a bit of a better example of what that deprescribing plan looks like. So you can see simvastatin here is just plain old stopped cold turkey, as compared to pantoprazole, where you can see the sort of explicit nature of the taper with the taper instructions and dates. And in the far right-hand column, you can see some pretty explicit instructions about monitoring for adverse drug withdrawal events for participants in the trial. So primary outcome here was survival at 12 months. Secondary endpoints were clinically relevant endpoints like admissions, falls and fractures, quality of life, function, frailty, dementia-related symptoms, and some important measures of med appropriateness. So when we look at baseline characteristics, it's important to note that 17 long-term care facilities participated, and there were about 100 participants randomized to each of the 3 arms. Now that is under the a priori power calculation of needing about 300 participants per arm to meet full statistical power. So it is one caveat. You can see for baseline characteristics here, participants had a mean age of 85, largely female, some pretty significant moderate to severe functional impairment, moderate comorbidity, moderate frailty, and some really significant cognitive impairment, right? So mean MMSE of 15, I think only like 30% of the total cohort had an MMSE above 23, so really pretty impaired. Participants were taking a mean of 10 medications. 7 of those were potential deprescribing targets. So when we look to the results at 12 months, when we look to the primary outcome of overall survival, we really see, survival, we see no difference in 12 months between arms when it comes to survival. So it's pretty reassuring, but again, underpowered to really fully assess this. When we look at the secondary endpoints that we mentioned earlier, we don't see any significant differences in secondary endpoints, except for difference in total med number amongst the blind intervention arm of about 2.5 meds. So in both of our intervention arms, total med number reduced by about 2 meds. That's pretty substantial. If we kind of go back in time to this talk last year and some of the interventions I know Amy talked about last year, those were on the order of about 1 medication. So to see this robust change of about 2 meds is kind of neat. What's also neat is that we didn't see a subsequent increase in the use or number of PRNs or an overall change in DBI score for better or for worse. We also saw no significant differences here in adverse drug events except for a greater rate of more severe adverse drug events in the blind control arm, which makes sense. They continued to take more meds, so perhaps they had some more risk introduced there. So all in all, this makes me feel a little bit more comfortable climbing on board the deprescribing safety train, right? Particularly for older adults residing in long-term care. I was really excited to see the robust decrease in med number without the increase in PRNs or impact to the other safety outcomes, though a little bit bummed that they were underpowered to really fully address survival. And not on the slide, but I was also really excited to see the implementation of the sort of placebo-controlled, double-blinded component of this trial. The over-encapsulation I thought was pretty neat. So as your tour guide and history buff, let's talk about trains, right? So many of you may have taken our local transit system, the MBTA, which is also known more commonly as the T. Did you know that the first underground electric subway was invented right here in Boston? And it's one of the oldest actually that is still in use. And so you can still ride some of the old rails. Knowing the T, they probably still have some of the old original trains in service. It's kind of an inside joke if you're from Boston, but you can actually go and check out some of the old rails and check out the historic placard on the corner of Tremont and Park Street. Now, it's not really like a tourist destination to like, ooh, go look at this historic placard, but if you do go there and you do take the T, you're right next to one of my all-time favorite places in the city, which is Boston Common and the Public Garden, which is really pretty this time of year. So check that one out. And our next stop on the train is to talk about deprescribing costs. So show me the money. And we're going to do that by looking again at the OptiMed study. And here we're going to look at a cost-consequence evaluation of this study. So this was a within-trial cost-consequence analysis from the Australian health sector perspective that looked at 2022 Australian dollars. From a cost component, there were 3 things that the study authors looked at: cost of the intervention, cost savings of deprescribed meds over the 1-year time point, and the overall cost to the Australian healthcare system. From a consequence perspective, they looked at incremental QALYs and some of the secondary endpoints that we saw earlier. So we look at the cost results. The total cost of the intervention was about $240 per participant, really driven by the cost to the Australian healthcare system of conducting the residential medication management review, followed by pharmacist time and nursing time. From the perspective of cost savings, they saw an average of anywhere from $165 to $330 saved per participant just by thinking about med savings. So the total net cost to the Australian healthcare system per participant was anywhere from $7 to $90 per person over that 1-year time period. So if we were to extrapolate that, as the study authors did, to all of the potentially eligible long-term care facility residents living in Australia, that could in theory save the Australian healthcare system anywhere from $1.3 to $16 million per year that could in theory be reinvested elsewhere. So from a consequence perspective, we don't see any significant differences in overall qualities between any of the arms, and no significant impact, of course, on those secondary endpoints, which is probably largely due to a power issue. So all in all, this is really a nice way to say we can get some savings here, sans consequence, particularly again as it relates to the population of older long-term care facility residents that were a focus of this intervention. There's really minimal input cost when we look at the total cost of the intervention. The utility consequences, didn't bear out, favorably. It's probably hindered by lack of power. And then finally, it makes it a little bit tough for us to delineate cost effectiveness just by nature of this being a cost consequence evaluation. So we've talked about savings, but if you're looking to spend some of your bucks while you're here visiting with us in the city of Boston, I recommend that you do it at one of our local markets, like the Boston Public Market, which is really accessible from here if you're looking to stay in the city. But if you're here for SGym and you're here through Sunday, my top recommendation is to go and check out the So What Open Market, which happens on Sunday. It is one of my absolute favorite things to do in the city when I'm here on a weekend. So definitely check that one out. So Amy and I would not be true Bostonians if we didn't give you some wicked smart take-home points from our talk today. So number one, look beyond geriatrics and primary care. We see some interesting differences and some interesting perhaps gaps when we compare geriatricians, primary care providers, and specialists. And I know there are many of you in this room who are focusing your area of expertise on looking at some of those differences with specialists. Number two, microlearning is really effective, but there's a need to engage physicians in microlearning education modalities. And that's not unique, right, to deprescribing. That's across the board. So, an opportunity to perhaps enhance self-efficacy if we can get physicians to engage. 3 and 4 kind of go together from my perspective. It's how do we, think about getting buy-in from patients, and that personal touch might really drive change. So really this relational component to deprescribing success, and the value of communication, which is something that we heard a little bit earlier from the communication work group. Number 5, deprescribing is safe, at least when it comes to long-term care residents who are older adults, and perhaps deprescribing in that population can save some money without sacrificing outcomes that can be reinvested in other meaningful ways in long-term care. So with that, we'd like to thank you for joining us on our tour of the deprescribing research in the past year, but also our tour of Boston. So if you'd like to tip your tour guides, we've got a cup up here. Feel free. You can also Venmo us if you didn't bring cash. But we've got some recommendations on the last slide. We hope you'll check them out, maybe find some of your own, and have fun while you're here in our city. Thanks.
I'm sure if we have time, but if there's questions or comments or things that people want to discuss further.